All right. Thank you, everyone, for joining us here today. I'm sure a few folks will still trickle in since it's right at 2:30, but we'll kick things off here. My name is Lauren Adler. I'm a fellow and associate director of the Center on Health Policy here at Brookings. Just some quick logistics here, right? We're going to do this panel for about 75 minutes. We'll close off a little before 4 o'clock, and then for the folks who are here in person, we'll have a little reception afterward. Across the way out the back, folks will show you when that time comes here. But feel free to stick around afterward, and then hello also to the folks on the webcast here. So we have this event here today to talk about payer-provider vertical integration. Just wanted to kind of give some quick intro to sort of guide a little bit of the discussion here, and just sort of start with the headlines here, right? We've already heard from United Health Group CEO, for instance, told Congress that they employ about 10,000 physicians. It's about 1% of U.S. physicians in the country, and then they affiliate with another 80,000. We have some work underway looking specifically at primary care, and it's even a little bit, there's more intensity. There's even the sort of penetration is even starker when you look specifically at primary care. And right, I brought up United Health Group's Optum. They are the sort of biggest player here, but they're not alone. Humana, Aetna, CVS Health, Elevance, right? There are a number of insurers who have been moving into sort of acquiring certain provider elements here. Now, so what should we make of this transformation? That's where I find interesting. Right now, there really is very limited empirical evidence on the sort of pros and cons and how to think about this integration of payers buying physician practices and other providers. You'll hear anecdotes suggesting that insurers may succeed in steering patients to lower cost sites of care, some of which they may own as well. We do have the only place we really do have empirical evidence is that this sort of vertical integration does tend to lead towards more aggressive coding in Medicare Advantage that drives up costs for the government. And we have seen recent great reporting from the Wall Street Journal, Stat, and others really driving home, even specific to Optum, that at least seems to be probably part of, at least suggesting that's probably part of the story here. But really, there's no research here that really weighs on some of the core anti-competitive harms that you might think about here, or gets sort of evaluating the sort of net welfare impacts of this trend. And that's both why we're hosting this event here today and why we at Brookings, along with Tyler Braun to my left and others at Cornell, have a lot of research looking into this specific topic. We're far from alone on that as well, but I'll be biased towards myself and the people here on this panel. But with that, I wanted to introduce our excellent panelists sitting to my left here today, who bring decades of experience analyzing both insurer and provider markets, and have spent considerable time on our topic here today, right? Insurers acquiring and integrating with healthcare providers. And I believe 3 of our panelists today have all spent time at the Department of Justice, for instance. So I'll do quick intros, and then I'll start asking folks questions. Feel free to elaborate on my relatively quick introductions at that point. I'll go from all the way from right all the way to the left here. Dr. Aditi Mehta is the Economics Director of Enforcement in the Antitrust Division at the Department of Justice, where she's been working for nearly 20 years. As many in the audience know, Department of Justice has an open antitrust investigation reportedly into United Health Group. And then we have Dr. Robert Tyler Braun, who is an assistant professor at the Weill Cornell School of Medicine, and has multiple research projects, including with me, underway on the topic of insurer-provider vertical integration. And then moving left, Dr. Corey Capps is a partner at Bates White Economic Consulting and is one of the leading experts and has been for a long time on healthcare competition. And then lastly, but not leastly, we have, last but not least, we have Dr. Martin Gaynor, which apparently I can't talk, but Dr. Martin Gaynor, we pulled out of retirement. But as recently as a few weeks ago, he was the E.J. Barone Professor of Economics and Health Policy at Carnegie Mellon. He's also previously spent time at both the DOJ and the FTC. In our antitrust agencies here. Before kicking things off, I wanted to let two of our folks give their kind of quick disclosures, one from the government end and one from the consulting end. So DT, I'll leave it to you first if you want to give the quick disclaimer here.
Sounds good. So I just have to give the standard disclaimer. So the views expressed do not necessarily reflect those of the United States Department of Justice.
That's also true for me. But my actual disclosure is that, I do work on behalf of the FTC, DOJ, state agencies sometimes, but I also work on behalf of private entities in the healthcare sector, sometimes involved in vertical integration of the types we'll be talking about today.
Great. And with that, to kick things off here, Tyler, I wanted to start things by asking you the sort of big why, right? Why do you think we're seeing this recent surge in payers acquiring physician practices, ASCs, and other types of providers?
Yeah, it's a really good question. It's a complicated question. So when we first started doing this research 2.5 years ago, we kind of wanted to hear from the individuals and the organizations that were acquiring these entities. And so we conducted numerous interviews across physician groups that were acquired by Optum, Humana, Aetna, executives at these organizations, what we call payviders. It's a kind of a dumb name, but that's just what we call it and Wall Street calls it. As well as coding and software engineers that help build up the algorithms and softwares that these organizations use to try to just get an understanding of like why this is happening. And I think from a broad perspective, I think the first thing that comes to mind and what one of the large themes that came out of it was challenges for independent medical groups. Okay, so they have big difficulties in maintaining independence due to market dynamics, right? So they're losing market share and bargaining power, and there's this hyper competitiveness that's taking place in the U.S. healthcare market right now, where consolidation of market health plans, which make payment negotiations much more difficult, hospital system consolidation, right? So a lot of these independent groups find it difficult to recruit and train and retain physicians, nurses, and other skilled nursing workers. And probably most importantly, there's a lack of capital to grow, right? So especially with the need to increase in size to participate in value-based care. So that's one big theme that popped up. Second one is that there's a lot of provider side factors that are helping drive this payvider trend, right? So for older physicians, especially baby boomer generation physicians, are selling their medical group as a lucrative way to wrap up their career and retire. And then younger physicians have trained in a corporatized system and view selling to a corporate owner as an ordinary in today's system, where physicians in the middle of their careers, they find this to be the most conflicting. And they've trained at a time of greater independence, but aren't advanced enough in their careers to treat a sale as a windfall, right? So those are two broad themes. The other third broad theme is that these payvider organizations typically have a longer term perspective to this, right? So compared to a private equity firm, you've probably seen a lot of news about private equity firms acquiring medical groups in the media and new research coming out. Compared to private equity firms, insurers aren't looking to flip and sell in about 3 to 7 years. So an example of this is Optum made their first acquisition in 2007, and they have yet to sell any of their actual physician groups, right? And from when we talk to payvider executives and physicians, they say that the insurers might be a better suitable teammate because they have better alignment, right? So both medical group and the payer benefit as patient outcomes improve. And contrary to hospitals and private equity, who traditionally generate more revenue regardless of quality of care, and plus, insurers in the value-based care era that we're in can help physicians a lot more in the coding expertise needed and the capital to grow. So I think those are kind of the three overarching themes that we've seen from our interviews.
Yeah, great. Now, Marty, yeah, feel free to others to chime in here.
Thanks, Tyler. That's really helpful. It's really good to hear evidence being gathered on this. I'd just like to say a few things coming from the other side, from the payer perspective. And these are things that one either hears or sees. Again, I think we definitely need more evidence. But one thing has to do with profit opportunities in the Medicare Advantage program because of a few things. One, just the growth of Medicare Advantage, of course, due to demographics. Medicare itself is growing. There are big shifts away from traditional Medicare and toward Medicare Advantage. Reminds me of the story, there was a famous bank robber during the Depression, Willie Sutton, and after much effort, he was finally apprehended, and the FBI asked him, why were you robbing banks? And he just looked at them and said, because that's where the money is. Well, why are United, Cigna, all these companies getting into Medicare Advantage? Because that's where the money is. Moreover, if you own providers in nearly every part of the healthcare space, you can do a few things. You could take advantage of risk adjustment and engage in what's called upcoding, so you enhance your payments without increasing your costs. You have control over very, very large amounts of data, which both enable you to do a better job, as it were, of upcoding and also control utilization. You can take advantage of the fact that Medicare Advantage payments are very high relative to costs. As a matter of fact, they were just recently increased. And another thing that is not Medicare specific is regulation on health insurance companies called the medical loss ratio, in which they're required to have profits that are no higher, or sort of expenses be a certain proportion of premiums. That means that they are capped in terms of how much they can earn, but if they own providers, they can increase, at least on paper, the payments to those, be in compliance with the medical loss ratio, and keep all that money in-house. Moreover, there's a lot of cash. These companies are sitting on lots and lots of cash. I believe it's just a few years ago, maybe someone else can verify this, United was sitting on about $25 billion a year in cash. And that abhors a vacuum, just like a quarter in a 5-year-old's pocket burns a hole in it until they've made it to the candy store. Not much different for CEOs. They're engaged in empire building, and I think that has a lot to do with what we're seeing. We'll come back to this later, but if you're listening, you're not hearing anything out this that sounds like, oh, this will drive costs down, this will benefit patients, this will lead to more coordination of care. These are motivations that are purely about profit seeking.
Marty, you went right for the jugular.
No sense in wasting time.
Just quick touching, since we jump into jargon a lot on healthcare panels. Medicare Advantage is not quite jargon, but just as a reminder for folks listening, Medicare Advantage, right, is the private healthcare plans that seniors and folks with disabilities can buy their Medicare coverage through, and which has grown to be more than half the program, and where we've both sort of alluded to this now, but right, the key thing here is you get paid, the Medicare Advantage plans, these insurance companies, right, you get paid based on the risk profile of your patients. So if you can make your enrollees look sicker than they really are, or at least sicker than they might appear, the same person might appear to be in traditional Medicare, you get paid more money. So there's just a lot of money on the line there. But I think just to end on Marty's point, I think ending point there leads to what I think my next question is for Corey here. Right, I certainly have at least heard anecdotes of the more positive side or potential for the side here. There's all the standard jargony double marginalization type of arguments. But Corey, I wanted to just sort of ask you if you know, what sort of efficiencies might these vertically integrated payers unlock? And, you know, is there any credible evidence that some of this is happening?
Sure. I think it was on. Okay. Sure. So the first thing is to say quickly on the coding front, more intense coding, I think intense maybe is a neutral word. Upcoding presumes you're increasing payments without increasing healthcare delivery. If you also do a better job at preventive care and screening and so forth, that will also generate more codes and possibly higher risk scores if you discover more cancers, more diabetes, treat obesity. So there's a second side to that. And that type of preventive work is not really well incented under the fee-for-service model, where you get paid, where you as a provider get paid for volume. So the theory of vertical integration, at least a major part of it, is that it creates an aligned organization where, and usually, by the way, the hospitals are not part of the integrated payer and provider. It's really physician groups and the payer. So you get the one entity, namely the physician, who has the most expensive medical device, which is the pen. And you give them incentives to control cost, and in principle, you can bring systemic costs down while improving quality through preventive care. There is evidence. By the way, these aren't mutually exclusive. There could be upcoding alongside true measures at advanced value. There's evidence for both. I think Marty may mention some papers on the upcoding side of things. If you look at preventive care and Medicare Advantage plans, there's a recent study from a consulting firm in Ovalon in partnership with researchers at Harvard Medical School. They found a 70% reduction in readmissions for hospitals, 50% reduction in preventable admissions for preventable inpatient admissions, comparable medication adherence, but fewer problematic drug interactions. So that would be one example. There was a 2021 paper that also found similar evidence that there was a good job for the vertically integrated payer providers at preventing patients from going to the hospital and coming back when they got out. So there's definitely a second side to the vertically integrated coin.
No, for sure. That's a sort of a question, right? You hear about the different payment structures, for instance, that these plans sometimes use to pay providers. I'm sort of curious if there's sort of thoughts on, are they changing the way, are these Optum, really United, Humana, are they paying their providers differently? Are they not using fee-for-service? Are they using more capitated models? Do they have different quality incentives, that sort of thing? I don't know, for anyone really.
I mean, I can speak to it a little bit just from interviews that when Optum makes an acquisition, they look for physician groups that typically may do fee-for-service, but are willing to go to upside risk and then eventually transition to like a full capitated risk-based model.
Is that may be different for different types of specialties as well. So you may see that more in primary care.
Yeah, so these large multi-specialty practices that they're typically acquiring.
Both United and beyond. I mean, I see some that just carry over the professional services agreement that basically have a flat salary and then RVUS incentives versus rolling out pay for performance metrics and then maybe moving towards full risk. One thing that underlies that is it is possible for physicians to get paid more for meeting metrics and maybe even for bearing risk. All of that entails overhead management processes, and I think that goes back to the fundamental driver of a lot of what we're seeing is that it's really hard to be a 1 or 8, even 7 physician practice these days. And so they want to be bought by someone. Insurers are one, but not the only option in that space.
So let me just raise a couple points. One is about fee-for-service payment. It only leads for incentives for providers to do more if the payment is higher than the cost of doing more. And so for private health insurance, for a lot of Medicare, that is the case. But for example, historically, Medicaid, the problem was the opposite, and that was a fee-for-service based system. So there's nothing inherent in fee-for-service. It's really where the fees are set relative to the cost of doing more. And it's also what gets paid for. Preventive care could be paid for under a fee-for-service system. There's nothing, pun intended, that prevents that from happening. Nonetheless, so-called value-based care, value-based payment, which often includes capitation, which is a fixed dollar amount per enrollee that providers get, has become very popular. But a couple things are important to be aware of with regard to that. One, it shifts risk from the payers, from insurers to providers. And insurers are in the business of bearing risk, spreading risk, taking risk, and you're shifting risk to firms that don't have core competencies to do that. So that becomes one issue. The other question, again, is sort of what the incentives are under that kind of system. A flat dollar payment, no matter what you do, gives a strong incentive to do as little as possible. That can be counteracted by competition in the market, reputation effects, professional standards, that kind of thing. But we shouldn't think neither that fee-for-service is the worst of all possible ways to ever pay healthcare providers, nor that capitation or some flavor of that goes under the name value-based payment is the best of both possible ways. Like anything else, there are pros and cons to that. And as people pointed out, fee-for-service payment is used by many of these consolidated organizations. It depends a lot on the particular situation.
I think I just add one point. So there's how the practices are paid. I think there's other contract terms that can change too from an acquisition, and in particular whether they can work with other insurers. So whether they can be in network or what exclusives are put in. So I think those can also have a big effect on competition in the market.
Yep. Marty, a question that your comment just inspired, which is you argue that the insurers are large and sophisticated at bearing risk, and so they're the efficient bearers of risk. On the other hand, if the medical doctors are the decision makers, therefore they're the efficient decision makers if they see the costs and benefits of their medical decisions, say the testing or other regimes they implement, then is that an argument for vertical integration?
No, I would say not necessarily. I think what you're getting at, Corey, you tell me if I'm not reading you correctly, is in order to get incentive right, you're going to want docs and other providers to bear some risk. Right. And then the trick, of course, is what is the right amount of risk. If they don't bear any risk at all, then they probably won't have the best possible incentive. So that's something we know. So to be clear, I was not stating or taking the position that providers should never bear any risk, but the notion that we can simply move all the risk downstream onto them, that I don't think is supported. Okay. Does that make sense?
Yeah, it does.
Yeah.
I also just wanted to add on one of the questions we got from the webcast audience was sort of asking a kind of follow-on question to what we've been talking of how do you think about any potential spillover effects here, right? We think of spillovers in a lot of domains here, but right, are there any changes being pushed by these vertically integrated payers that might have impacts more broadly on traditional Medicare or on the employer plan market?
Well, sure. I mean, one thing that we're going to talk about at some point is, are there potential harms from this kind of consolidation? And those would not be confined to Medicare or Medicare Advantage. They would spill over, onto traditional Medicare, onto private, and onto Medicaid, for that matter. And that would be true also most likely about any efficiencies as well. I don't want to omit.
I think on both fronts, it's hard to picture a doctor, saying, let's do everything totally different for the 11 and 15 a.m. patient, and then we'll go back for the 11:30 patient, doctor and the staff. So if a consequence of this is rolling out protocols, evidence-based medicine, or possibly harms to competition, it would likely be beyond just the narrow contracts.
I can just say from preliminary work that we're doing currently, when you look at these vertically integrated organizations and you parse out, let's say, United MA plans, other MA plans in fee-for-service within one of these vertically integrated provider groups, risk scores for United Healthcare and a United vertically integrated practice, as well as other MA plans, risk scores are much higher than they are in fee-for-service. But most of that I don't know what the right term is here, but upcoding doesn't come from health risk assessments or retrospective chart reviews. It all comes at the encounter level, right? So they have a concurrent review process that they use. So when they're capturing everything at the encounter level or at the visit level. But when you look at the non-integrated groups and you look at the MA plans that are not vertically integrated within those practices, what you see is that most of the risk score contribution comes from the health risk assessment and the retrospective chart review. It's not originated at the encounter level. So that's kind of a spillover. But what the ironic thing is that when you look at the fee-for-service population within the vertically integrated groups and the non-vertically integrated groups, they're almost virtually the same.
So that's interesting, right? So then that's implying that the Optum doctors are picking and choosing which patients to code more intensely. Not that implying that might be what's going on there.
Possibly, we don't know.
I think that's always a very interesting question here, right? It is obviously, I mean, most likely a integrated payer is going to try to encourage providers to capture any diagnoses the patient might have at the encounter level. I've always sort of wondered, would an Optum physician care about the Humana patient that came through the door, or the traditional Medicare, not care about them, but would they care about coding them, making sure that you've nailed down every diagnosis code possibly? And that's always, I don't know the answer to that, but that's always been an interesting question to me.
Well, to the extent that, say, if you're talking about an Optum physician practice, they're capturing the payments from another health insurer, then they also have an incentive to do that.
Well, on that note, then I'll, we sort of went through some of the pros. Marty has already kind of touched on some of what he views as some of the harms here, but it might be helpful to kind of walk through, Marty, if you could, sort of what types of anti-competitive behavior, which I don't think we've really touched on all of them yet. What sort of anti-competitive behavior is most likely when an insurer is operating physician practices?
Sure. Happy to do that, and then I'm sure we can have a stimulating discussion about that. So one thing we've already talked about that's not a harm, direct harm, or a competition harm is just sort of excessive spending. If risk adjustment leads to what's called upcoding, again, sort of coding of the severity of illness that is above and beyond what the cost associated with treating that patient, and it's done in a systematic way, that leads to excessive spending. So gaming ways to get quality scores higher for Medicare Advantage without actually providing higher quality, that also increases the payments that these payers get from Medicare Advantage. That increases their profits without actually changing how the kind of treatments the patient gets, let alone the quality of care. To the extent that puts them in a stronger position that can disadvantage rivals, make it harder for new firms to enter the market because they may not be able to do these kinds of things. They may not be as able to compete as effectively. That's an indirect effect. Again, to the extent that this consolidation leads to much higher profits for these firms and they're sitting on lots of cash, that gives them an advantage in the market that disadvantages rivals, that fuels acquisitions. These are all indirect effects. There can also be conflicts of interest. So previously independent physicians are now employed by another party, and that party has it in their direct interest to try and have physicians behave in a way that's profitable for the owner, not necessarily what's best for the patient. That can have an impact on the care that patients get. It doesn't necessarily have to be a bad thing, by the way. If physicians were making decisions that were providing excessive care or inappropriate care, then that sort of thing can be reined in. But you can also see how there is a conflict of interest built into this as well. As far as impacts on the market, if these firms, say United, Humana, et cetera, have acquired providers throughout most of the healthcare system, and that becomes necessary in order to compete effectively. Now notice there are a lot of conditionals here because we don't really know the answers completely to these kind of questions yet. But if that's the case, then that means in order to compete effectively, if you need to have a presence, not just say as a payer, but as a physician practice owner, as a hospice provider, as a data holder and data analytics provider, so on and so forth, pharmacy benefit management company, if you need to be present in all those areas in order to compete effectively, if you can't do that, you can't compete as effectively. It also makes entry that much harder. If these firms change the ways that their providers behave, if most of patient referrals now are kept in-house all the different levels of providers that are owned, then that disadvantages rivals. That can lead to rivals having a hard time in the market. They don't get the patients that they otherwise would have. This also can lead to a race, an arms race, as it were, among firms in the market, where they're all trying to do what this consolidated firm is doing. Notice I'm saying consolidated, not integrated, because consolidation and integration are two different things. Consolidation is simply acquiring firms. Integration is actually knitting together a coherent entity out of all those things. And consolidation is not an easy thing, but integration is extremely hard. There's also control of data. These firms sit on very, very large amounts of data. Under risk-based payments, the access to data is very, very important to operate effectively under risk-based payments such as capitation or other forms of value-based payment. If it's hard for others to access data like that those data in particular, or data like that can put rivals at a disadvantage. There's also the possibility of the opportunity for foreclosure. There also creates a greater opportunity for collusion if these firms are sitting on lots of data, not just their own data, but data of their rivals as well. In addition, I'll just mention one last thing, as if all of these weren't enough. The presence of the regulation, the medical loss ratio regulation, not only creates an opportunity for regulatory gamesmanship. So as I said, the regulation says that a health insurer has to spend X percent, 80% or 85% of their premiums on medical expenses, 85% for larger firms. If you are at that 85%, or if you're beyond it, you are constrained by the medical loss ratio. If you own providers, you can pay them more on paper and get yourself in compliance or below the medical loss ratio. Now, suppose that the following were the case. Suppose that you're a payer and you have market power. If you don't own providers and you are at the medical loss ratio constraint, say at 85%, even if you possess market power, you can't increase your prices because you will violate the regulation. If you now acquire providers and you pay them more, again, on paper, it doesn't really matter because it's all the same pocket, right? Then you're no longer constrained by the medical loss ratio and you have the ability to exercise that market power that you did not previously. So that's yet another way. Now, I do want to stress, and I'm sure we'll all come back to this, that these are all possibilities. We don't yet, certainly in terms of research evidence, we don't have a lot of direct research evidence on these things, but they are things to look out for. I'll say one last thing, and this is not a competition issue, but as these firms grow larger and larger and they have more and more of individuals in the country enrolled in their health insurance plans, then we face another kind of risk. Suppose any one of these companies suffers some kind of very serious financial loss, then what happens? So in principle, state health insurance commissioners, state health insurance departments are supposed to be paying attention to this, and they do, but I'm not sure that in terms of the operating scope of these firms that state health insurance regulators are necessarily up to that task. Outside of that, I think everything looks great.
Yeah, I don't know if anyone else wants...
the dismal and the dismal science.
No. I don't know if anyone wants to... I mean, I think, right, there are a lot of these potential harms. I think it is also often helpful to try to draw out which of these are sort of the most concerning. I don't know if anyone else has thoughts on or any of these sort of the most concerning elements for you.
I just had a question for Marty. So just for clarification, so with the MLR, right, let's say that you're not vertically integrated, your premium is $100, you have to distribute 85% of that, right? So if you were to own physicians, you distribute the $85 to that medical group, right, is what you're saying. And then they're not capped by the MLR where they could pay them $50. And so that's a $35 margin. Is that kind of what you're saying? And so on the accounting sheet, that would just be an intercompany elimination, right? And so therefore it skirts around the MLR.
Sure, there's a way to skirt the MLR, but moreover, if the payer's pricing was constrained, right, if they're at at the cap. They can't increase prices if it's profitable,
Right.
because they're being more profitable to violate the cap. Now, if they just say, suppose they were paying their providers $100, they pay them $150, at least on paper.
I see what you're
Now
saying.
they go below the cap, and then they can increase their prices. Now, this is a hypothetical. Does that make sense, Tom?
Totally. Yep. I
Right.
think we're saying the same thing.
But that is going to, you're sort of overlooking the role of competition among plans in two respects on something like that. First, they have to bid the cost of providing Part A and Part B services. If we're talking about Medicare Advantage, there are MLR caps in other sectors too. But for Medicare Advantage, the behavior you're describing would result in a higher bid, lower benefits, and membership loss to other plans, which is kind of what you said in your initial assumption, which is assume that they have market power or face limited competition. But to the extent there is competition, and this is sort of built into the MA system, that would be one mitigant that you'll lose members.
100%. Yeah, I mean, the situation, the scenario I just described, the hypothetical, if there's strong competition in that market, then it doesn't even arise.
And also it can be the case that, the spending directly on payments to physicians, if you own groups that account for 15% of physicians in a given geography, that's going to be like 15% of 25% of spending. So you've got like 4% that you could then raise by 1%. So it's going to be a pretty blunt tool.
Potentially, yeah.
On
I
the
think
MLR side.
so. One thing I think your first point, Corey, really points to the importance of competition. Right. It really, really reinforces that. And so I think that, and thank you for doing that, because I think that's really something that's an important takeaway from this. In the presence of tough competition, at least that particular issue doesn't even arise.
Sort of two follow-ons on that, right? I think one, right, it's interesting, right? The only empirical evidence I know of on the MLR finds that it's had roughly zero effect on premiums so far. And then I also always think about, in this context, what's the sort of straw that broke the camel's back here, right? If, say, you banned insurers from owning provider practices, they also have PBMs, they also have dialysis centers, right? There's a lot of provider types. There's also probably ways to game the MLR elsewise, right? How much is this at the margin really having much of an effect on the MLR, right? Could they just avoid it in other ways, even if you got rid of, this sort of vertical integration?
Well, bear in mind, so your point's excellent, Lauren, that it's the entirety of medical expenses that matter. But for example, for United, they're not unique, but as an example, they get to count payments to Optum, which is an intermediary, towards their medical expenses. They don't have to only count the payments that. So Optum is a company owned by United Health. Optum does a bunch of things, including owning physician practices, but that's not all that they do. The dollar for dollar payments that go to Optum get to count as medical expenses for this medical loss ratio. They're not restricted to only using the payments to providers that Optum then makes. So it's not that the problem goes away. If anything, I think it's a bit more severe.
Although, having looked at MA bid workbooks, and you can find older ones online, right, it does tend to be the case that the 85% that you're outlining isn't binding, meaning most often profit margin plus overhead is less than 15%.
Right, and then this is always the question for something like this. Does that mean that they have successfully gamed that, and we're looking at that outcome, or does it mean that it's really not an issue? And I think just from looking at that fact, we can't tell.
Yeah. I think they've been similar from before to after. So there's not a good but for world, but just for 20 years of MA bid workbooks, they tend to not be up against the 15% or the 85, depending on which way you define it.
Thanks.
I think that is interesting, right? I know the Kaiser Family Foundation always puts out their sort of average MLR in the large group market, so not Medicare Advantage, but the other sort of big market here, and they do this cool employer survey, and that's pretty consistently been, the MLRs in the large group market have pretty consistently been 89, 90% for a couple of decades now. So it is sort of an interesting point here. And then, interesting thing about the MLR is that, most folks in the private market are getting insurance through a self-funded employer plan, right, where the employer is the actual one sort of fronting the risk and paying the bills at the end of the day. For them, the MLR doesn't even apply to them. So sort of throwing in the extra notes, but I do think, one question which I find interesting here is, today we're primarily focused on this sort of insurer-provider, insurer-physician group integration here. But obviously, we've kind of alluded to it here. That's not the only type of entity being acquired by payers here. I'm sort of curious if there are additional concerns related to insurers expanding sort of across the healthcare continuum. I'm trying to avoid getting bogged down in like PBM issues, but are there sort of broader questions there?
So I think there's one merger that happened in 2022 where United Health Group bought Change, which was a software company that provided transmittal and claims editing for claims that were going from provider groups to insurers. And so the antitrust division challenged that in 2022. We lost in court, but some of the issues were kind of what Marty has been talking about whether, so I guess the way I think of it in antitrust world is whether United Health Group was using a product that its rivals used to disadvantage the rivals by increasing the cost of the product or decreasing the quality in some way. But another issue that came up there, which I think is becoming increasingly common across different industries, is thinking about how the merged firm can use the information that it gets, right? So in this case, it was potentially getting competitive sensitive information. There's a whole issue about firewalls and whether they would the insurer arm would be able to access that. But if they were getting this competitively sensitive information and how they could use that competitively sensitive information from their rivals to dampen incentives to innovate or other things that would matter. So it's not exactly in the insurer provider space, but sort of in a lot of the same things apply.
Aren't you going to say we told you so?
I was not.
I can add to that a little bit. Not in the same vein as like Change Healthcare or data repositories, but in the instance of Optum, for example, they've created these things called market performance partnerships. These are management services for non-core companies for a provider group. So think of like IT, revenue cycle management, analytics. What's interesting about this, it allows the physician group or the medical group or the healthcare organizations that partner with Optum to remain independent, so they don't have ownership. So that's one mechanism of these relationships that Optum and United Healthcare has been building. They've also been acquiring independent physician associations. So a lot of the times they kind of use this as like a first glimpse where they'll try to recruit small physician groups into the IPA. And then typically they have a favored nation clause in there where they would get first look if that group decides to sell. So that helps build up their pipeline of prospective target companies to acquire. And then they've also have acquired in the long-term care space, home health and hospice, as well as surgical ASCs, surgical care affiliates, the largest ASC chain in the United States. So they have a pretty versatile and broad range of things that they're acquiring.
Yeah, and so I think pretty much everything except for hospitals. Nobody wants to own hospitals, apparently. And again, I think one thing we've been trying to give over is you can see the potential upsides from this because there are spillovers across these various parts of the healthcare sector, and there could be benefits from coordination. I've made it clear I'm fairly dubious about that. That's just my personal take, but we've seen lots of consolidation, lots of so-called integration over time in healthcare, and it has not really paid off. It doesn't, now maybe this time is different, and that would be just wonderful if it were. On the other hand, now you have entities controlling nearly all of the various parts of the healthcare sector. If we get to a point in order to compete effectively, you have to be something like that. And we've talked about United a lot, but a lot of other large health insurers are moving in this direction. One question I ask myself is, how many markets in the United States can support effective competition between entities like this? I live in Pittsburgh, Pennsylvania, which is a wonderful place. Could we have United plus Humana? Is the market big enough for two firms like that, let alone them trying to enter against University of Pittsburgh Medical Center, but we'll leave that for another time. Los Angeles, New York, Chicago, probably, possibly Washington, D.C., possibly Philadelphia, much of the rest of the U.S., I don't know that the population is there to support two of these large entities, let alone three, in order to have any competition whatsoever. Now, we're not at that point, and it's certainly another scenario is certainly possible in which independents or entities that are integrated in some of these parts but not others can compete very effectively against these large, I don't know what to call them. Well, Jonathan Cantor and I've called them platforms or conglomerates, whatever you want to call them. But that certainly, to me, raises an issue that is of great concern. And I think we have to keep a very close eye on this.
Well, the biggest economies of scale barrier is hospitals, right? So go to a smaller town and it's going to be hard to have more than one or two hospitals. For lots of the parts that we're talking about, like home health, was mentioned before, primary care physician groups, you can have a relatively small to mid-sized town and multiple competing entities, even if they are only platforms. So while you say that there are large diversified platforms, and I think we can name at least 5 of them, whatever the blue is in a relevant state, Cigna, Aetna, United, Kaiser, plus Kaiser's Risant, moving around. So you can actually have scaling up and consolidation and larger, more sophisticated entities from a national perspective, but any given local market can still have 2, 3, 4, or 5 of them. The one thing they can't have is 5 hospitals with 100,000 people.
Yeah, certainly. Well, I mean, with hospitals, I think scale economies are actually like not that huge, 250, 275 beds, more like it. You still have to be of a certain size, but here in terms of risk bearing, and having the data and analytics infrastructure to support that and do that effectively. I don't think we actually have good estimates of how big you need to be and the extent to which you need to own entities as opposed to just contract for those kinds of services. I don't think we really know the answers to those things yet, but I think that does change the game, Corey, in terms of, or potentially, in terms of scale and how big you need to be in order to compete effectively.
I think the ownership versus contracting question is an important one, and what can you achieve with ownership that you can't via contracting. On the scale front and IT and support, I think that is one of the factors driving the consolidation, is that knowledge and expertise doesn't necessarily have to be housed in the local market where the physician, the home health, the hospice, and everything else is located. So you may be able to get the scale within a state by having a large entity in the state, also working in partnership with possibly ownership or one of these other relationships you alluded to provide IT and expertise.
I'll say this. I think one thing that we haven't mentioned is, like, for example, in the Optum model of acquiring medical groups, they see all other forms of insurance as well. And it's strategically done because of the cost and the capital that is needed to keep these open. If they were just to only see United Healthcare patients, they would be operating at a loss.
That was sort of what drove the United Change decision and why DOJ lost, is that it was sort of viewed as there was too much to be lost by undermining relationships with external partners after the vertical integration. At least that's what part of what the court wrote.
Yeah, I mean, certainly that's going to be a big question in all of these market foreclosure or, raising rivals cost sort of questions.
Right. But for example, we've been talking about evidence. I mean, I think one thing we would probably all agree on is are there substantial gains from doing things in-house as far as the taking risk-based payment as opposed to doing it arm's length, all the things that are associated with that. I think we can tell stories both ways, where you could do it arm's length. There are independent data holding entities. You can have contracts with them, et cetera, et cetera. But this is a very important point, I think, which evidence is really needed.
Yeah. I also just wanted to touch on one thing here. Corey actually did mention them in the same breath, but we are talking here today largely focused on insurers buying up physician practices and really buying up every provider but the hospital. There are lots of hospital integrated payers in the country. Kaiser Permanente has been around for a long time. I suspect if you polled on sort of brand names, Kaiser Permanente would probably have a more positive ring to sort of average citizen. Here, I mean, Pittsburgh is UPMC versus Highmark, right? I wonder, right? How are we thinking differently about this sort of integration where you're cutting out the hospital versus the, at least much more common historically in the US? I don't really know the other country side of things here. How much in the US, how much, the sort of more traditional hospital insurer integration? The better or worse? Are there sort of...
I think there is more data on hospital payer, hospital acquisitions of physicians, and it's not because that's more important. It's because there's more readily available data. And so, what was the maximum you gave earlier? But anyway, economists look for the keys under the light, not necessarily because that's where the keys are, but because that's where the light is. So that's better studied, I think, than the MA and risk bearing side so far.
Yeah, I mean, I think that is an important phenomenon. It is different because you're talking about a consolidation among providers, and certainly with regard to, say, doctor practices and hospitals, you have mergers of complements, which important potentially offer efficiencies. But as Corey said, we have a lot more evidence on this. There's a lot of evidence that doctor prices go up following these acquisitions. Hospital prices go up following these acquisitions. The FTC did a 6B study. We have one of the people in the room who was directing that study. We have another person who wrote the dissertation on this precise topic. So we have a lot. One difference is that not only is it a different phenomenon, we have a lot more evidence. Let me say just one last thing, and I'll be quiet. With regard to Kaiser and other exemplars of integrated care, like Intermountain Healthcare, Geisinger, there are a handful of others that are always given. Please, I would love to hear of good, careful, rigorous evidence on these entities. There are a lot of anecdotes, and maybe indeed they are absolutely fantastic, but people seem to refer to them without actually having evidence on their performance.
No, that's right. That's a good point. And we don't have you up here to be quiet, so that's fine to talk here. So with that note, I wanted to turn over to Aditi here to ask sort of specifically, obviously Department of Justice is interested in these topics, right? How is the DOJ approaching these sort of payer-provider deals today? And more broadly, sort of what tools exist under current law and sort of where are the pain points?
Yeah, so, we have seen quite a few payer-provider deals of late, and we have a variety of tools for looking at them. I think part of it is just doing a lot of what we've been doing up here is, except that we have subpoena power, basically. So a lot of what the economists at the Antitrust Division do is learn as much as they can about the industry by interviewing industry participants, by looking at documents, and sort of really understanding how competition works. And thinking about what the strategic documents are. We look for the motivation of the deal, but I will say just because the reason that the provider is selling their group is well-intentioned and not anti-competitive, that doesn't mean that we're not going to be looking for potential anti-competitive effects. So it's but it is important to understand the motivation of the deal and kind of see what the players in the market think is going to happen. So I feel like I have to now say some successful challenges we've had in the healthcare industry. So back in 2016, we challenged 2 health insurance mergers, but these were in the healthcare space. And so we dealt with some of the same issues we deal with here in thinking about the regulatory overlay and how that changes the incentives for the firms. But these were horizontal deals. They operated in the same line of commerce. They were in the same geographies, many of the same geographies. And so we had our standard antitrust toolkit where we looked at market shares. We have some models and merger simulation models that we can do to see what the changed incentives are from the merger. That is those, and courts were familiar with how to look at this. We had a lot of precedent on how to look at these types of deals. So that's not necessarily going to be the case on these payer-provider deals, which don't have this sort of standard horizontal component. But there is some relevant case law that looks at some of the foreclosure type theories that Marty was talking about. And then the 2023 merger guidelines, which is a document that the DOJ and FTC put out to talk about how we look at enforcement practice, how we do enforcement, have some frameworks that are useful for this. So one is, I think, Marty talked a lot about thinking about whether the merged firm may limit access or to a rival to make the rival less competitive in the market. So that could mean once they buy the payer group, they can, in the extreme, not give access to the rival insurers for that payer group, so not let them be in network or not contract so they can be in network. But that's sort of an extreme. It can also just be raising the price of that provider group to its rivals, decreasing quality. You can talk about whether that's actually practical or can happen. But that's sort of a standard framework that's used in antitrust where, and a lot of the same tools that we use for other types of mergers are going to apply there. So you want to see how competitive the market is, right? So you want to know the rival insurers, what other substitutes do they have available to them? How important is the competition between the insurers? So even if you made an insurer slightly worse off, how would that affect the competition in the market? So we look a lot of the same things like market structure, market shares, and other sort of tools in our toolkit. And then another potential framework that's laid out in the guidelines and that we think about often that can apply here is whether these deals lead to an increase in the likelihood of coordination, and that can happen for a variety of different reasons. There are tools available, and I think we have been thinking about them and trying to learn as much as we can about the industry. There are some, there's still work to be done, so more research helps us. There is a lot of data that's available, but I think one thing is while there have been a lot of deals, looking back, it's the same challenges that researchers face is looking back at the past deals, like has enough time passed for there to be the effect that you would think. I think one other thing is that we tend in antitrust to look at one deal at a time. Here, there's a lot of deals, and there's a lot of deals that are unreportable, so we actually don't even see them. So if a merger isn't over $125 million, we don't automatically, it doesn't have to be reported to us, so we might not, it doesn't come in front of us necessarily. And so I think one thing to think about is it right to look at each individual deal, or if there's multiple deals in a geography, does that change the way that you analyze it? So you can imagine, for example, that one provider acquisition doesn't change things for rivals very much, right? They're not that one single one is not very important for rivals, but if you have a couple of those deals or a few of those deals and you look at them together, then it may have a bigger effect. So I think that's, there are just a lot of deals, a lot of them are small, and so I think we need to think about whether it's appropriate to look at each one. The other, and then there is just, as you all know, a very complicated regulatory overlay in healthcare. And so that's going to affect the incentives of firms. It's going to affect how they realize their market power. And so we spend a lot of time sort of thinking about what we think the effects are going to be and how likely it is going to be to reduce competition and lead to harm for consumers.
Great. So actually just one thing, right? You mentioned challenges to monitoring activity here, right? Are there policies, are there sort of ways to overcome some of those reporting challenges or some of the monitoring challenges?
So the reportability is just that that limits whether it's reported to us, and we get these filings that you get when they have to report a merger to us. So we get some initial documents. But if we find out about a merger, and then we can open an investigation and look at it. And so there's also limited resources. And so there's some decisions that need to be made, but we will often in investigating one potential merger hear about other potential mergers that just happened or that are about to happen. And so there is some way for us to look across deals.
So one thing I'll mention is that in my view, there needs to be competition policy for the country as a whole, and antitrust enforcement is a key part of that, but it's not the only part. And let me touch on that specifically in the context of acquisitions, mergers and acquisitions that are not reportable. For example, I think the Department of Health and Human Services obviously plays a very, very big role in the healthcare sector, just like Department of Transportation plays a very big role in the airline sector. Health and Human Services took on the task of monitoring and recording these activities, and that information could be broadly available, publicly available, but available to the antitrust department division, to the Federal Trade Commission. That could help address that, and that could be part of a whole of government approach to competition policy, just one part.
As I said, that's a good touch up also just for other, right, this is Brookings, we do policy here. So, right, I think that's sort of the other interesting question here is, right, sort of antitrust, but also beyond antitrust, you know, what policy levers does Congress and state policymakers have that they can, or what they should consider here, both at the regulation level or legislative? Or should they not be doing anything, right? I think that's or do what they're doing right now.
Well, one thing is to draw a line between the risk adjustment that we talked about for the first quarter of this, where I think of that as a regulatory and oversight question, not an antitrust question. And in fact, if you look at there's new rules coming out now. Marty mentioned that payments are going up to Medicare Advantage plans, which is true, but the baseline was 9%. And then CMS changes to risk adjustment brought that down to 6%. And then other CMS changes brought it down to 5%, which is still larger than they expected was going to happen. But the point is, a lot of regulatory changes have brought down the expected payments to MA plans for next year by 3% in the risk category, although they're going up on net. That's regulation. And if there's not enough auditing, or auditing should be vigorous or something else, then that's fine for Congress and CMS to do. I don't think it's a core part of antitrust. For antitrust, what I heard is Marty gave a long list of factors that can be a concern, and many of which I agree can be a concern. I gave factors that also go in the other direction, some of which other people on the panel agreed with, which tells you figuring out which sets of concerns actually apply or don't apply to a given transaction is a hard task, and it proceeds sort of one by one when the DOJ and FTC do it. So I'm hopeful. Is hope a policy recommendation? I'm hopeful that their budgets will keep up with the size of the economy when it comes to staff and investigations.
Me too.
Yeah, I think I agree with Corey. I mean, that is a big challenge. I mean, folks at the antitrust division at the FTC have been just working flat out. Of course, there are fewer people now there now than there had been previously, but the challenges remain the same, or maybe even are greater. So resource constraints are a real major issue for the antitrust enforcement agencies. This isn't necessarily legislative, but I think there are things that Medicare can do to help address some of the issues that or the things that provide artificial incentives for consolidation. If consolidation happens because by doing so you can make a better mousetrap, that's great, right? And there certainly is consolidation like that happens in the economy. There are mergers and acquisitions that are efficiency enhancing, that are better for everybody. But if they're if they're an artifact of way Medicare pays for something, then Medicare needs to address that. And by the way, these are not new issues. Folks at CMS are very smart people. They're very savvy. They know about that. The way that there are intensity adjustments for coding, those are applied in the same way to every single plan across the board. That gives an advantage to plans that do a lot more than those that do a lot less. So not doing it the same way for everybody. Everybody gets the same haircut, regardless of how long their hair actually is. So an obvious thing to do is either make it insurer plan specific or have groups or something like this. This is not new. People have been thinking about this for a long time. Reducing the amount, or rather increasing the amount of the adjustment to reduce the profitability associated with that is another reform. On the MLR front, I think Corey alluded to this, doing a better job of monitoring and accounting for what are actual expenses, changing some of the rules about what can count and what can't count might help. One could consider doing away with the regulation entirely. I don't know if that's on the agenda or not, and we'll obviously have to think carefully about whether that results in things being better off. But there are quite a few things that can be done, at least in principle, by executive agencies without having to go to Congress and ask for legislation.
I'll make one pitch. So the Antitrust Division has created an anti-competitive regulations task force that's is looking to identify state and federal laws and regulations that create unnecessary barriers to competition. There's an open comment period until May 27th. So I encourage people, if they have ideas, to go to our website and submit a comment.
That'd be great. Yeah. I think that sort of teed up one question that I always have on this topic is how much is this all just driven by Medicare Advantage? To sort of put a finer point on it, if Medicare Advantage or sort of coding, you couldn't use coding to make a lot more money, would we be even seeing this trend? Would Optum be buying providers? Would Humana be doing this? Or would it just like basically be a trivial share if that wasn't sort of the core thing here?
I think you'd be seeing physician groups bought up no matter what. It could be private equity, hospitals, health plans, Amazon, or someone we haven't thought of yet. Your specific question is answerable, right? Because there's wide variation in Medicare Advantage penetration across the country, and I actually don't know if that's related at all to health plan acquisitions of physician groups, but maybe a grad student will find out for us.
Yeah, I mean, there has been work trying to get at, for example, whether site-specific payments are drivers of hospital physician acquisitions. There has been research on that. So just like Corey said, I think that's a great question. I think in principle it is answerable by research, and there's probably a PhD student at Harvard, Princeton, or Stanford working on this right now as we speak. Okay, I'll stop.
Or Cornell.
Well, here's one other thought, and this is something I don't know. I suspect it would require legislation. There are a lot of things driving folks into Medicare Advantage when they enroll, and one of those is the fact that traditional Medicare on its own exposes people to unlimited amount of risk. There's no such thing as an out-of-pocket limit in traditional Medicare. So people either enroll in supplemental plan, Medigap, or they go increasingly into Medicare Advantage. And Medicare Advantage can look very, very attractive because there are a lot of zero premium plans. My wife and I have just gone through this long and extremely confusing and difficult enrollment process, so I have some familiarity with it. We know that facing unlimited risk, you have to pay all of that. So that's something that certainly could be addressed that might require legislation. And of course, there are budgetary impacts of that. So not an easy thing, but certainly seems like it would be a sensible thing to do.
I also just wanted to touch on the sort of maybe more aggressive forms of regulation here, right? I think there's been a move back on the sort of corporate practice of medicine side at the state level here, right? I'm just sort of curious, right? We've talked a fair amount of potential pros and harms, some folks talking more on harms than others, right? Do some folks think that corporate practice of medicine statute should simply bar insurers from owning physician practices, period?
I think there are different organizational forms trying to find a way to build a better mousetrap in healthcare, and none have solved it. And if you pick exactly one of those and ban it, I think you risk not letting competition make the choice. So if you can protect competition, firms will offer different models, just like if you like Android, you can buy any phone from anyone. If you like iPhone, you can only have iOS software from Apple. Those two models, one is vertically integrated to a greater extent than the other, and they compete, and consumers decide who wins. If you protect competition, it's probably better to let consumers pick rather than ban one model.
I think Corey's point is a good one, and so I hesitate to encourage complete bans, but there are laws on the books in many states. Some of them are not necessarily particularly enforced. And the other thing that we have to be honest is physicians haven't always been particularly great guardians of the interests of patients. We know that physicians respond to financial incentives. There's nothing wrong with that. But for example, with regard to surprise billing, physician practices readily contracted with private equity firms that took advantage of loopholes in payment to surprise bill patients when they had no way to anticipate or do anything about these bills, and the physician practices profited mightily from that. As a matter of fact, those practices strongly opposed legislation to ban surprise billing. So they're not perfect, but one might ask oneself the question, who would you rather have at the end of the day in charge of your care? United Healthcare or your physician? I think most would say your physician. I want to be clear, that's not a guarantee. It's certainly possible that United or Humana or Elevance or somebody else can come up with better mousetraps. We certainly don't want to prevent that happening. But I think we have to be cognizant of conflicts of interest in these situations at all, which is a long way of saying I don't know that we have a great answer. One sort of intermediate thing, which we do not, well, actually, we may have it in place in one place, is monitoring and oversight. So Corey and I are both familiar with the Netherlands Healthcare Authority. The Netherlands is smaller than most states in the United States, but they do have an entity in the Netherlands that gets information about everything going on in the healthcare sector, monitors it, reviews it, and has the right of approval of pretty much anything that goes on. The only place I know of in the United States that has something similar is Oregon. They have the healthcare
Massachusetts.
But they don't have any real power. Oregon, HICMO, what does HICMO stand for?
Healthcare market oversight? I'm just guessing.
That sounds right, actually. So they actually have teeth. So we actually have at least a little bit of an experiment going on in the United States with that. Now, again, I don't not necessarily advocate it. This is the way to go because there are some costs associated with that, both just sort of running something like that, and there could be errors of commission as well as omission. But I guess I would throw that into the mix as something that's intermediate, saying, well, we're not going to outright ban these things, but we are going to keep an eye on things and review them.
Yeah. Great. I think with that, as we're getting close to time here, I wanted to open up for audience Q&A. I was going to kick things off, take a few questions from folks, and then I don't know if anyone has questions first, though. It's, Conrad. And please introduce yourself for the folks on the webcast as well.
I'm Conrad Milhopt. I'm currently working on this in the Senate, and I used to be a research assistant for Lauren here at CHP. I'm curious if you folks have any thoughts. There have been some proposals around structural separation, specifically in the PBM space, not allowing PBMs to own pharmacies, or more broadly, structural separation of providers and insurers. This conversation has obviously gone through some of the benefits and drawbacks of VI, but sort of flipping that, when you think about what might be some of the drawbacks or benefits to just outright banning, you mentioned on the corporate practice of medicine, but I'm just trying to think through what might be some of the impacts of sort of saying that these sorts of ownership models should or should not exist flat out.
I think my answer was, or I know my answer was not specific to corporate practice of medicine. So in general, if you ban it, then you're saying the markets can't choose which organizational form is better. And that undermines consumers' ability to choose, so it should be done rarely, if ever.
So yeah, I think that I agree with that point, and then the question is sort of how much is lost and how much is gained. Consumers are often are not in a very good position to make informed choices. Often people don't have good information, or there are other kinds of things that are barriers to making effective choices. So one has to ask oneself the question. So you may address one kind of problem there, but by doing so, has that made things better or has it made things worse? I'm not giving an answer, but I can see, like anything else, there are some potential upsides with that. But you are preventing private parties from experimenting with certain kinds of organizational arrangements, and there are no question there are spillovers between providers and payers.
And I'll try to make it more concrete in very short order. Suppose you were concerned that facility-based billing was driving hospitals to buy up physician groups. One thing you could do is say, I ban hospitals from buying up physician groups. The other thing you could do is say, we've created a distortion in the underlying payment mechanism, let's go fix that. And so probably the latter is going to be the more effective answer. And maybe if nothing else works, then you look to blunt instruments.
Yeah, so just coming back to that, and I think comes back to something that we were talking about earlier, this sort of whole of government approach to competition policy, as it were, empower CMS to make changes to payments and regulations. Again, medical loss ratio is not CMS, right? But make changes to those things that are artificially inducing consolidation and try to make them as neutral as possible. If that requires legislation, that's a great thing for Congress to act on, unrelated to this, but sort of hospital doctor stuff, right? Site neutral payments have been on the agenda for quite some time. that's a very straightforward thing. Push something like that forward, and then see what happens. Let the market go forward.
Are there any other questions from the audience here? Yeah. We'll wait for the mic, please. Thanks. And if you could please introduce yourself.
Tom Timberg, independent economist, but your discussion raised all kinds of questions for me. But the thing that were immediate is, first place, what about antitrust activity about discriminatory pricing between your own providers and independent providers who you have to pay? And it seems to me there are a couple of other questions that are going to emerge. We ask doctors and other medical professionals to testify all the time in cases in court, which are also of interest to insurance companies. And will all the people connected with insurance companies be disqualified for testifying in connection with those cases? And the final thing, what's going to happen on malpractice, I don't know, because we now have deep pockets to sue, and we have real questions about the credibility of the witnesses who will testify, and I think that eventually might become a major thing. So I wonder if you have any comments on these three issues that occurred to me.
So I think on the charging different prices to your own insurance plan versus other insurance plans, I think that is part of this raising rivals, potentially could be part of this raising rivals costs theory, where they may have an incentive to charge their rival insurers more. And so I think that is something that is a concern and something to be thinking about. On your other two questions, while I work with a lot of lawyers, I'm not, don't know that I'm qualified on witness development to that extent.
Anyone else had
Well, if the Robinson-Patman Act enjoys a revival, and it's popular in some quarters, and that may actually cross partisan or party lines, then we might see more of the kind of thing you're describing, which could be related to the issue of raising rivals costs, but isn't necessarily the same thing.
Right. Any more questions from the audience here? Right. I guess with that, we'll close things out. And again, thanks everyone for coming here in person or tuning in online. And yeah, we'll certainly be plenty of more work and activity on this issue going forward. But thanks for coming.